As I got another rhyme, another rhythm for y'all to listen. I'm never quitting on my mission. I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going, better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain. Keep on working, open curtains, haters swerving, cause they ain't ready for your final version. Ooh, I'm never gonna give up, fall down, I just gotta get up, yeah.
You're listening to the Tom Ficklin Show on WNHHLP 103.5 FM, your home for community radio.
Good morning, everyone. And it's tomorrow in Australia. And I kind of often mention that the time is kind of a relative thing. And sometimes we want to kind of focus on the eternal present of life. And actually, each day is a present, and it's a gift. And we're going to talk about gifts and how to maintain our gifts from a medical standpoint. We'll be more specific, of course, but also just in terms of being proactive and taking ownership of your health. Today's topic is diabetic retinopathy, and how to kind of combat that I wouldn't say plague, but that incidence of that happening. And it is, quite frankly, you may or may not know, one of the leading causes of vision loss in the United States. And unfortunately, many diabetic patients, and I was so excited to do this show because I'm sure anyone who listens to this show, and we post it and broadcast it worldwide, knows someone that's suffering from diabetes and or might even be pre-diabetic. But diabetic patients do not receive or take advantage of their recommended annual screening in their eye exams as often as they should. Patients with diabetes and actually folks that might be kind of impacted, or some might say oppressed and marginalized, and particularly if you're a racial or ethnic minority, are at an increased risk for vision loss. Our guest today, and it's really a blessing to have Dr. Christian Harris Wanyanwu with us, and because she is a recognized expert in this area and is beyond being concerned about health disparities, but has been proactive and instrumental in decreasing health disparities and kind of just beating this drum of the heart, mind, body, and soul, how we could all kind of rally around it and support one another. And so she's dedicated herself to really understanding these underlying factors that contribute to this unfortunate reality of diabetic retinopathy. Dr. Kristen, good morning. How are you?
I'm great. Thanks for having me. How awesome is this? This is the
Good.
best.
It's so awesome that we're even joined by Reverend Dr. Leroy O. Perry Jr., who's with us, and Dr. Perry's pastor of St. Stephen's AME Zion Church and cultural ambassador to the Yale Clinical Research Program. And the esteemed Reverend Alvin Clayton has also found time to join us, pastor of St. Stephen's AME Zion Church in Bridgeport and cultural ambassador to the Yale Clinical Research Program. Dr. Magnan, you share with us a little bit about your background. I was looking at your resume and the Yale Medical School background on you, and I could spend 30 minutes just reciting your accolades in that regard. But with your doctor, your MBA, you have a Master of Health Science. But share a little bit with us about retinopathy and how you got started in this, and kind of introduce yourself to us in this context.
Sure. So I'm Kristen Wanyanwu. I'm Associate Professor of Ophthalmology and Visual Science. I am a retina surgeon, and I am from Ann Arbor, Michigan. So go Blue. I was born and raised there and had always had kind of a spirit of activism. I am the granddaughter who's now passed. My best friend in the world was my grandmother, and she was an entrepreneur. She ran a store, but she really was always about community. And she would, where she lived, she would teach children to read, and she would, share her time with them. And people didn't have resources, she would always make sure that they had what they need. And she loved education. And she would always say we grew up together. And so, I think being steeped in that and in her love of community and her love of education, there was I, right? And then I have two, beautiful parents. My father taught AP Calculus in the public schools forever. So many people had Mr. Harris, and he was, a staple there. My mother was a middle school counselor, also in Ann Arbor Public Schools, and they were the first in their families to go to college, and then they also got master's degrees. And I always ask them, like, why wouldn't you stop at, your bachelor's? That's amazing in and of itself. And they said, well, all our friends were getting masters. Which is like mind-blowing to me, and how important also community is. I had two older siblings. One passed away. He had a brain tumor when he was very, very young, and then passed away when I was in training. And I think, growing up with a special needs sibling actually grows you up a lot and allows you to see a different perspective of the medical field and medical perspective. Also, my father, from when I was 2, I remember him calling me Dr. Harris. And I think that also is, pouring into what you think the next generation should be. So I don't have a memory of, not wanting to be a doctor or, all of that. And I think the advocacy that grew alongside of that, I just had this concept of fairness when I was little. I grew up in Ann Arbor, Michigan, and we always had a very large achievement gap. And then they called it like the Black-White achievement gap. And I remember serving on those panels as a high school student to talk about like what were the root causes, what were the issues, what we could do in our college town to be able to combat some of the things that we know were important. I was an intervener in the affirmative action case as a high school student, and that, bled over into when I was a college student at Michigan. And I, did a lot of activism to the Black Student Union and otherwise. And my mother was so worried about it. She used to tell me, she would say, I don't think doctors do this. And she was like, just please don't get arrested, because we just had a really strong sense of justice and Black community and Black equity. And it was just really important part of who we were and what I did then. I went to med school at University of Pennsylvania, where they saw all of that and thought I'd be a great physician. And I continued to kind of do that work. I did Student National Medical Association there. And then that's where I actually found ophthalmology. So I always tell people that at that point, that was our first iteration of Ben Carson. So gifted hands, neurosurgery from Detroit, right? I'm from Michigan. So, any Black person at that time that wanted to be a doctor wanted to be a neurosurgeon. We all did. And so, but I went to med school and I met the neurosurgeon, and I was like, maybe this is not for me. And I had to figure out what I was going to do. And that's how I fell in love with the eye. So at UPenn, we have to spend a week doing ophthalmology. And I always say at the beginning of that week, I was kind of like, are these even doctors? What are they even doing? And then by the end of that week, I said, oh my gosh, these are the happiest surgeons on earth. When they see a problem in their patient, they get to fix it. They get to have these long-lasting relationships that I really, truly enjoy and love. But then you also get to intervene. And I'm like, this may be the right thing for me. And so what I had to do at that point was figure out how I was going to pair my advocacy and activism in that world, which was something that really hadn't been seen. So my mentors were in family medicine, emergency medicine, and some of them said, like, are you going to go be an eye dentist? What are you doing? And I really let's see, I get this from my mother. When I'm going to do something, I'm just going to do it. And I will figure out what the data is to support me doing it, but you can't talk me out of doing it. So what I did is I looked in the literature and I found some of our leaders in ophthalmology in equity at that time, which are, Paul Lee and Dr. Eve Higginbotham. And I said, well, there may not be a lot of things that have been done, but that's an opportunity for me, and I'm just going to figure this out. And then also in the meantime, it was the time of uninsured. It's interesting because the Affordable Care Act has taken beautiful root into our health system, and it's hard to remember the swaths of people that didn't have health insurance at that time. And it was just devastating to me that as a med student, I could say, okay, I want my patient to have this, this, and this, and that there were other forces beyond healthcare that could tell me what I could do. And I just was really frustrated by that. And so it turns out a University of Pennsylvania has a business school. And I said, well, I need some of these business facts to be able to, be at these tables that I think are going to be really important. So I went to Wharton. The funny thing about Wharton, though, is that I didn't know that people that go to Wharton already know business. And so I went there and I had no idea about business at all, which is hilarious because 80% of the people in my class already worked in finance and entrepreneurs and all this fun stuff. But it was a great learning ground for me because I really got an intimate, up close view of what was happening outside of healthcare, outside of, you know, provider patient relationships. And I think to this day, it really is a great foundation for when I'm building programs or when I'm designing systems and interventions. I really think about the things that we were taught, right? Sustainability, revenue, like how are we going to make sure this lasts? And then what are the implications of what we're doing? And so it was a beautiful place for me. I thought for a while I might do business, but then I experienced a business emergency, which had to do with the slide deck. And I said, oh no, this is not going to work for me. There's no way I'm going to run to do some slides. I just got to get back to healthcare. So here we go. So I went to training. I learned how to be a retina surgeon in Chicago. And actually, Yale was my first job. And so this is my first job, and that was 8 years ago that they took a chance on me as a young budding retina surgeon who I gave my talk on social determinants of health. That was in 2015, and my job talk. And they said, oh yeah, we get that. We're in New Haven. And I didn't know what that meant, but I said, if they'll give me a chance, I'll take it. And Yale has been a beautiful place for me to grow a career. I have the best mentors in the world, from, you know, Dr. Marcella Nunez-Smith to Tisha Johnson to, you know, both Desires, Mr. and Mrs. Dr. Desire, to, you know, Darren Lattimore, to Dean Brown, you know, my chair. It's just the humans here have curated an environment for me to be free and whole and to work on the things that I think are really important. And it has just been phenomenal, really, really awesome. So I'm really grateful for that opportunity. I'm really grateful for the work that I'm doing. The Academy of Ophthalmology is doing cool things now. What's happening in the world from regards to the people that are thinking hard about these problems and just pushing no matter what, and to be able to be in those waves and be in the fray and try to make something better than what we've ever seen is better than any day. So, and I get to do it every day. Such a big deal.
Well, it's certainly a blessing to have you. And Dr. Wanyanyu, I want you to kind of share with us what is diabetic retinopathy mean, and also want to bring in Reverend Clayton and Reverend Perry after that to kind of have a full-fledged discussion. But share with us the definition a little bit of what is diabetic retinopathy.
Sure. So diabetic retinopathy is one of the diabetes-related eye disease. And when we talk about it, we always talk about it in terms of the systemic environment. So diabetes creates inflammation. So when you have blood sugars that are too high, it creates an inflammatory state in your whole body. I always tell my patients to think like if you have a cut and that redness that comes, right? That's the inflammation, except for it's inside. And what it does is it changes the blood vessels. So it's really important to think about diabetes as a cardiovascular disease. We talk about it as glucose, but it's really like a vessel disease. And so what happens with the eyes is the changes from that inflammatory environment change those vessels, and those vessels have difficulty doing their job. And the job of the vessels, right, to deliver oxygen to the tissues. So in the eyes, how it manifests and how it looks is the vessels leak. So the vessels that usually have these beautiful tight connections between all of the cells, all of a sudden can't do that because the cells that protect those vessels die because of this environment. And so then you end up having fluid where you shouldn't have fluid. And that part is particularly called diabetic macular edema. And so it's the swelling that comes from fluid being outside the vessels instead of in. There's other complications as well. Some of the vessels get little outpouchings called microaneurysms. You get bleeding in the back of the eye, and those vessels tend to break and bleed. The other thing that happens is there is a scaffold covering the back of the eye, and that's called the vitreous humor. And you get abnormal vessels that grow. And so basically they grow along the backside of that gel. And then over time, that gel kind of pulls on those vessels. And that's how you get what we call attractional retinal detachment, which is the most severe form of diabetic retinopathy. And it's a blinding entity and a complication from diabetes. And one of the reasons I became a retina surgeon is because the retina surgeons are the ones that fix tractional retinal detachments. Other things that are important is that most of our eye disease from diabetes, blindness is preventable. We've known for 40 years how to prevent blindness from diabetes. And so the reason I do the work I do is because, our Black community, our, Latin communities, our indigenous communities, our communities that are low resource, go blind more, they get seen less. And we have to figure out how to design systems that actually work to keep our sight, because it's staggering the way that the disparities play out on different levels. And so it's really important for us to, one, know how this happens, but also to be able to interrogate systems of oppression and interrogate our guidance on how we can figure out how to get to the people that we know we're concerned about.
We're going to take the deep dive in terms of the research that you're involved with, but I guess before we do, I guess wondered, Reverend Perry, what kind of thoughts might be circulated in your brilliant mind, and Reverend Clayton, you have a brilliant mind as well, so I'll come to you next.
Oh, that's exciting, your journey. It's amazing. As a side question, did you know in Detroit, Nicholas Hood or Denise Hood? She was a judge and he was a pastor of Plymouth. But they were both Yaleys, and I just thought you might, since they were very active in protests in Detroit.
At that time, no, I don't, but the last name sounds familiar. So there may be a generation or two that I could pick up on the way, because you're right, it's not that big it's not that big of a community. So I bet you if a couple degrees, we could figure out something.
So with the subject at hand, one of the things that I had been aware of in our community, one of the things that I noticed is that Black people just seemingly do not have access to two things. One is dental care, and the other is eye care. And, I think the average person thinks that they can go into the Walmarts and buy some vitamin for the eyes, and they don't have to worry about anything, because the idea of having an eye doctor also has that string of saying, well, do you have insurance to afford that eye doctor? And an optometrist is not an ophthalmologist. And so you can go into Walmart and get your eyes, but you really, if you need to see an ophthalmologist, most Black folk just do not have the funds, resources, connections to get that done. And that is a sad state in a nation as wealthy as ours.
Yeah, I would definitely agree with that. I work with the American Academy of Ophthalmology, and we're doing some work on federally qualified health centers. I mean, I think for that reason, because they do have, necessary dental services, but eyes are not there. And so there's a paper that recently came out that we worked on to try to figure out where the eye professionals were. And that's not even splitting them off by ophthalmologists and optometry. That's just overall. And so, from our community, I think you're absolutely right. Where can you go for the uninsured or underinsured? What are the possibilities? I mean, fortunately in New Haven, Cornell Scott has a full functioning eye clinic, and we're grateful for that. But not all of the satellites have that experience as well. And I know Dr. Frazone, and I know that they, deliver excellent care there. Actually was referred to, they just got a new optometrist who's excellent, who referred me a couple patients there that were spot on. And I think, us figuring out what are the models, like you're saying, so how can we get people what we need, what they need? And so the Academy is pushing to say, yes, we think that everyone should have access to a comprehensive eye exam, no matter what. And we are going to start here at this level, which I applaud the Academy for doing. And that actually came out of, our racial reckoning as ophthalmologists, and our collective trauma of George Floyd, our collective trauma of COVID-19. And the ophthalmology community saw that we were behind on equity. And Angela Elam, whose actually husband is Charles Williams from Detroit. Actually, he's a pastor, so she's a preacher's wife. And so she wrote this paper, which is, our guide, our thought piece in ophthalmology about what to do next. But I applaud our CEO, Dr. Stephen McLeod, who said, okay, we're not going to just write a thought paper. We're actually going to do the work. And so I see the Academy kind of pushing from a policy level to say, okay, we want this level of care, But in the meantime, how can we interrogate our systems? So for example, the work that I do is 13 years ago, I published a paper on like risk stratification for diabetes and complications and eye disease. So we can say, if we have everybody, who are we really concerned about, right? Who are the people that we really are concerned that are at high risk for blindness? And a lot of our community falls in that level. You know, some of the things that we found out, foot ulcers from diabetes portend to poor prognosis, which means that if you have a foot ulcer, it's likely that your eyes are close behind. Why? Because we talked about it as a systemic disease, right? Systemic milieu, a systemic environment that provides then whatever is happening in your heart and in your brain, stroke, heart attack, is also happening in your eyes. So, and we also found that high in hemoglobin A1C, which makes sense, right? That's our marker, our 3-month marker about how well the glycemic control is doing, was really important. And so when I got to Yale, we interrogated that a little bit deeper, and we interviewed participants here and at Cornell Scott to say, okay, we know the rates are low. I think we interrogated our system and found it to be like 40–50% of who we thought who should have an eye exam. And we said, uh-oh, we're doing something wrong. And so what I love about the community engaged approach that Marcella Nunez-Smith has taught me, and that Tisha Johnson obviously is the queen of, is saying, hey, look, we're doing this wrong. You know, how can we get some help, right? How can we get lived expertise? How can we get community input? And, you know, I came to the cultural ambassadors, and I went to the CRE, and, you know, we, built a framework to try to say, okay, how are we going to do this? And the first thing that we do, I run the SCENE lab, which is the Site Saving Engagement and Evaluation in New Haven lab. And the first thing we do is risk stratification, which seems really small, like really basic. Like, okay, of course, like you want to know who's at highest risk, but that's what we do. And then we engage our participants. We give them a full eye exam, and then we engage them with Project Access. I'm sure you all know Project Access. That follows them for a year to say, okay, if we can build a community or resources around our community members that we are concerned about the most, and we can usher them through their other things that they need to do, can we keep them in the system? And then can we save their vision? Because we know they're high risk because we already checked. So I think those are the kinds of things and the models with our current resources as we advocate for appropriate systems and resources that really think about distributive justice in health and really think about where we really need to go, right? How are we going to do this right now because we are in a sprint? But then when we think about interrogating our systems and pushing forward, what are we advocating for and how can we advocate together?
Excellent, excellent. Reverend Clayton, let's hear from your brilliant mind as well.
Good morning. I am just so thrilled to hear this presentation, and that you started so early in high school. And you had, most students in high school, they want to be something one day and something else the next, but you had tunnel vision. But my thought or my question in a sense is, we rarely hear about people with loss of vision due to diabetes, and diabetes is so popular. I think it's somewhere around 18% of African Americans have the disease. So since it's so popular, what are your thoughts about getting this word out to our community to help us do better in this area?
Well, I'm glad you asked. This is so great. Okay, so we said I run the SCENE lab, and I'm so grateful because we've just been having a great time. So we we've got a grant from Yale. We're doing a co-designed application with community members, and our focus groups are at the Q House. And we love it there, and we love our participants. And that's one of the things that's important about the community engaged approach. But what I'll say is our participants, they said, hey, are you in charge? I said, uh-oh, yes, sir, I'm in charge. I'm from the Midwest, so I use my manners. And they said, well, we need to get this information to everybody. And it just can't be us. And what we found was our participants, they actually knew what to do. There's diabetes prevention programs in New Haven, and New Haven is a vibrant place to try to figure out how to be together, but they wanted everybody to know. They said everybody should have access to information, community, and details. And so what I did was a proper fact-finding mission. I started asking the people I know, I said, do you know anywhere where there's peer support for diabetes, or like where people can go and get that information and and grow together? And I think what's important about our diabetes is it's not just, oh, I need to do this for my blood sugar, so oh, I need to eat that. It's also like Dr. Tarika McCall says, life flow. Like, how do you fit it into your life flow, whether that's your finances or your work schedule or whatever those pieces are. Like, it's not that you just need to know the information. You need to know like how to make it work for you. So two things. So the Scene Lab, we're working on a date with the Q House, but we're going to have a dissemination party. And the reason I'm so excited about this is a lot of times we do research and people don't know what happens to it. And so for me, a huge part about the work is I want everybody to know, because the reason why this research is progressing is because of our participants and their willingness to share their life experiences, their willingness to come and join us as we try to figure out how to tackle this really important issue. So that's going to be this summer, and we're going to have it in the Q House on the patio. We're going to have a DJ and healthy food and little like infographics about all the things that we're doing. And then the other thing is, based on those focus groups that I had with Dr. McCall's team, we are actually also going to build something that's a monthly starting in the fall, and we're going to call it Seen Together. And it's going to be diabetes for community members. And I've been trying to tackle with what to present to community when I come and we start it, because it's going to be community, listening to community. We talk a lot. I talk a lot in general, but I think we talk a lot in academia. But we have to be good listeners about what our participants and community members really need when it comes to diabetes and education and care and all of that. And so we're going to start that. And then community is going to tell me what we need to do, who we need to bring. But I'm convinced that it's not, everyone says, oh, it's an education problem. And I do think there are aspects of this care that we need to elevate, but I do think it is something that we need to do together. And I want it to be mostly community members saying, look, here's what I know. Now we're going to fact check. We know we're in the age of misinformation, and we are not having anybody going down the wrong path on Scene Lab Watch. But I will say that I think a lot of our community members know what's going on. They just need the resources. They just need the help to figure out how to fit it in their life flow so we can all get healthy together. And so we are working on a time and a place so we can do that regularly, so people will know, here, bring your friends, bring your family that may not have diabetes, that wants to support you through this journey, so that we can get well together. And it's just an exciting time, because that came, if I didn't listen to my participants, I wouldn't have thought about that, right? I wouldn't have, even though I call myself a community researcher, right? But what our participants say always surprises me and always illuminates what comes next. And I'm grateful to have some resources to be able to pour into that. So we're doing that. And I will say one more thing. We were creating, when we were creating the SEAM program, which is this risk stratification and project access collaboration, some of our participants right away said, they were identified as food insecure, but they were like, you know what, I feel like I have enough food, but what I really need to know is what to make. And so we had a beautiful visiting student with us, Akua Frimpong, who's applying in ophthalmology. We're so grateful. She visited with me from Vermont for a whole year. And she would put together packets, culturally appropriate, like foods and packets and things like that, to say what we can substitute so that we can eat the things we love, share in community the way we like to share, but also like get well together. So it's just little things like that that grow, and big things that we can do and join together. But there's so many cool things going in New Haven. Like, I just feel so grateful to be able to participate and line up with what is going on already.
Well, we will certainly beat the drum loudly and consistently in terms of your events that are upcoming by all means. Reverend Perry, any thoughts?
Yes, I think that the holistic approach is so important, because I think, when we were coming up, exercise was, we didn't have cell phones. So we were exercising. We were playing street ball, basketball. We were running tag, and so, you know, I looked at a high school group going across the stage, and I said, "My God, McDonald's has really had an effect on all of us." But I think a lot of people, in terms of education, just don't know the drastic effects that it can have on your body. You know, I grew up in New York. I mean, I worked in New York for like 25 years in Harlem. I can't tell you the number of people who had diabetes who lost arm, leg, foot, toes. And most people looked at that as the major thing, but the eyes are as equally as important. It's like when I go to the ear, nose, and throat guy, I'm saying, I know they all work together. And so we've got to find a way. So my thinking is, when we were going to grammar school, every year we had to have a physical examination. I think that at some point policy should work toward everybody having a part of that physical examination and eye examination up until they're in high school. And then those who seem to be at risk could be followed and could be, you know, on a list as endangered as a possibility. And I think that's one of the ways that we might be able to challenge. And it's really hard to go into one place, like a community center, and you got the rest of the nation, the rest of the state, the rest of the Black community saying, I don't get to the Q house.
Yeah.
I live in another ghetto. And no one has this where I live. How can we somehow find a way? And we this is what we try to do through the Culture Ambassador Program. We have programs like this with Tom. We have a newsletter, but then our churches are beacon newsletters, and then our partners in the community, like the CAP agencies and the barbershops and the beauty shops and the parks and the rec halls. These are our beating drums, our African drums, to get the word out. So, you know, and Tisha Johnson is our drum major. We just had an Omega affair in Waterbury. We must have had 20 tables from Yale. We had 3 Yale doctors there. We had the vans there. I mean, those are the kind of events that we have to plan more of across the state, and particularly where we are, in order to really have an effect on the work that needs to be done.
I think you're absolutely right. It's so important. And I think in lots of different levels, though, for me, you know, I go and I submit my, you know, work to the national societies, and I submit it to get published. But I think also it's that parallel advocacy, right? So now I'm working with the Academy of Ophthalmology so we can have a toolkit for, like you said, eye docs that want to do this work, to say the how of it, because, you know, want to is great, but you have to be able to identify how you can do it well, right? How you create and curate those partnerships that you may not have in places that may not have always been the best neighbors, right? And so what does it look like to try to begin to have those conversations? I think as well, when I talk about the SEAM program, all around the country, they're like, we need a SEAM program. How do we make it, right? And so talking about scaling and other places that are interested in figuring out how to do the best. You know, I'm starting a group of like-minded individuals that are talking about eradicating tractional retinal detachments. That's this really bad, blinding manifestation of diabetic retinopathy. And we haven't been talking about it together, even though, like you're saying, there are pockets in the country where this is the most devastating. For me, I have people in their 30s, people that are very, very young, where their disease-defining presentation is with blindness. In America, you shouldn't figure out you have diabetes by being blind. That's not something that we should do here. And so what are the pieces that we have to put together to be able to identify how to make sure that we connect in a way that will save sight? And we are starting to do that. And I think for the communities that care about this and connecting And if we can get our docs all over the country and our communities all over the country to be able to say, this is something we really care about, and we can advocate for that on the highest level, I really think that we can change how we think about it. Because people don't want to get cancer, number one, and then they don't want to go blind, number two. And I think that is something that we haven't talked about on a national stage, particularly something that is preventable.
I have a question. When, as a specialist, by the time you see the people, they've already got something wrong. And so you're addressing something. What are the preventative measures from having to get to you?
Yep, absolutely. I mean, I always say I'm trying to put myself out of business. But it is really, you know, the figuring out how to incorporate lifestyle changes is imperative. And, you know, glycemic control is our number one factor. It's duration of diabetes, or how long you've had it, which is not as easy, right? You've had it however long you've had it. Some other things we are concerned about is maintaining blood pressure, which is something I know that our community is really concerned about. And it's really about, you know, how do we screen? You know, what does that look like? But it can't just be just screening, because what happens when you find something? And I always say that's almost worse, right? Like if you find something and you don't know what to do with it, or where to put what you found, or how to connect them to proper care, then, you know, what have you done? And so trying to figure out what the barriers are to that. We did a study, I'm going to say maybe 2018 or 2019, where we built a framework from the social ecological model. You probably have heard of that, right? Where you start at the individual and then you kind of go layers and layers to get finally to community. And, you know, one of the things that was interesting to us was the emotional context of having diabetes and the weight of having diabetes. A lot of our participants, if you thought about it, some of them were so afraid of getting eye disease that if you told them they had to come every day for the rest of their lives to take a picture of their eyeball, they would, right? Like they would be there. They're like, I'm afraid of this. I don't want it to happen. I'll do whatever you say. But that same fear, the thing we call that same emotion, some people said, you know what? I have enough going on. I don't even want to know. Right? I don't even want to know. I have a lot. Like, it's just too much anyway. The rest of this is too much that, you know what? I'm not going because I have enough to deal with. And every time I go to the doctor, there's something else I need, you know? And so it is not taking everybody as a lump, but being able to have individual conversations. So it's an interesting thing we talk about, because we have like a very large swath, huge problems, but we know we have to be local also. And that we know that the stickiest of interventions are going to be the ones that are, you know, with Reverend Dr. Perry, right? The ones that are with, you know, Reverend Clayton, right? Those are the ones that are going to stay and stick, because those are the, you know, cultural ambassadors that will be able to maintain, right? But we also know we have to have a national conversation that will push policy forward to be able to do that. And then I think also in community, we also have an individual conversation with our community members that says, what is this? What's happening with you? Right? Like, what is this? How does this resonate with you? What is possible for you and your family? Right? How can we build and design systems that make it easier for you to get the things that you need? And I think when I'm interrogating and asking those questions, it's got to be all of those. And we have to pursue excellence. We have to pursue excellence and equity, meaning that when we are designing new systems, we have to figure out what the appropriate metrics are. I always tell people, you have to know how you won. How did you win the game? Right? And so you have to be able to have the data to be able to support the scaling of the things that you're doing when you're designing it. And as an implementation science, that's what we do. You know, you all have had Dr. Calhoun on here as well. We went to undergrad together. I've known her for many, many years. And so she teaches me about implementation science. And she says, okay, it's not enough just to build something. You have to build something, you have to have the appropriate metrics, and you have to have the appropriate evaluation to know when you've won, right? And then how to keep winning. And so for us, these are the questions that we're asking. These are the data that we're collecting. You know, these are the community members that we need to interrogate our systems. I was just emailing today with Dr. Lucila Machado Ono, who is the new department chair for the informatics at Yale. And she is dynamite. She just came out with this article on equity and informatics. And that is what we need. We need communities that will oversee a lot of these algorithms, a lot of the things that are coming out in equity, so that we know that they're doing what they are supposed to do. And we need to have them written, designed, and built in ways that make sense to actually help us and not to keep us out. And I think that, to me, all the answers here, they lie in New Haven. I don't think the answers are at Yale, right? I think the answers are in community. I think we have to use the power of Yale as the apex of what we do. We're good at what we do. But then align that with excellent lived experience in community, and then I think we win. But we only win if we can hear those voices. We only win if we can know if we're doing a good job. We only win if it actually makes sense to make people healthier and advance equity. Otherwise, we still got to get to work.
Kristen, you got a lot of preacher in you.
Listen, I just get excited. I'm like, look, this is where we need to go. Let's get it.
Evangelism is a good thing.
Hey, we'll take it. We will take it. If we can save somebody's sight, I'm with it.
That's
Reverend
right.
Clayton, share with us.
Wow, I am just blown away here again by what I'm hearing. But another thought that I have is the social determinants of health connected with the eye disease are based upon or connected to diabetes. There's so many issues that we face, housing, poor housing, poor diet, the wrong grocery stores in the neighborhoods, transportation. There's so much that's keeping people in a certain place. So in order to fix the diabetes crisis or the crisis of this dreaded eye disease, we got to fix these other things too. So I just want to say that because it's vital to the work that you're doing. We can do all the work we want, but if we can't help the people that really need it receive the treatment, we're in trouble.
Amen. And don't forget about the racism. Like there are so many levels. There's so many levels that we are battling. But I'll tell you what keeps me optimistic. When I always say ophthalmology, we had our racial reckoning, and I was doing equity work before that. And everybody was kind of like, what is she doing? And then it came to light, with COVID-19, that this was something that was really, really important. And at that time, I always say, Marcella Nunez-Smith really illustrated how important all those pieces were on the national stage, on the biggest stage. And she taught us all that we all have to move all of the pieces together, and we all have our part to play. So at that time, that was the first time I got to contribute to, in the text for all ophthalmologists, there's a social determinant section. That was the first time there was ever any of that. Wrote it down for our doctors to be able to allow them to contextualize and understand something they've always known, right? That if your patient doesn't have appropriate resources, it's going to be harder for them to get well. But I think now that we have language to be able to say that, and we have administrative move towards addressing that, I think with CMS trying to say, okay, if you live in this zip code, how can we put the appropriate incentives to be able to make that community healthier, right? A friend of mine, Jonay Caldoun, was the chief medical officer of the state of Michigan during the pandemic, and she is now the chief health equity officer at CVS. And CVS is invested in affordable housing, right? And that's not a small thing. And the reason is because of who she is and what she knows about what's important about advancing healthcare. And so I think that we are starting to, like you're saying, get those pieces, because it is unreasonable to ask our communities, why aren't you well, right? It's not, millions of people by accident are sick. I always tell my trainees that. I was like, it's not a coincidence that, our blindness from diabetic retinopathy is a disease of the margins. It's not an accident that they're all either Black and brown, they're from low resource communities. It's a system that created that. right? It's an incentivized system that created that. And so when we are building our Band-Aids, right, we are saying in community, here's what we're going to do for now. I think it's a beautiful thing and very important to also call out the systems that have allowed this to happen, right? And that have allowed this to exist in this way. And that is heavy. But I think if we begin and we insist on saying it that way, then we can start to try to figure out what new systems look like. I always say in my lectures, we've never seen health equity. We haven't seen it. It doesn't exist, right? Like this is all dreaming. Fortunately, I'm a great dreamer, but we've never seen, what that really looks like because of our legacy of slavery, right? Because of the legacy of injustice and inequity, this is what we have. And so now, as we are with clear eyes looking forward as to what will exist in the future, being together in that initial foundation of where we started is imperative as we come in forward and we deal with what happens and what happens new, which is also why people are like, oh, how are you doing in New Haven? I'm like, New Haven just did a whole book on slavery and Yale. And I'm like, hey, look, and throughout the communities, that is new and fresh and vibrant. It shouldn't be, but it is. And so I think that as we start to have those original conversations about why we're all sick and have it as a systems conversation, then we can really figure out what to do next together. And as we, it's a beautiful time to be in New Haven, like with Concat and like just all of the innovations that are happening and the community foundation, like digging into all the beautiful things that can happen. And I always say community leaders that are leading and building for ourselves, that's just great. And that's a beautiful thing that's happening. So I'm optimistic because when we're seeing it clearly for what it is, then you can interrogate it, then you can ask the questions, and then we can build for the future. And I just am so happy to be around, right? Like, how cool is it? I keep telling my trainees, like, it's so cool to be in ophthalmology right now. It's so cool to be doing this. I tell Marcella, I text her, I'm like, oh my God, I can't believe I'm here to see what this is happening. Then it's hard and it's heavy. But I say we're like a flock of birds, right? Like you're in the front, you get tired, you fly in the back for a little bit, and then you come back to the front. Like we are all moving together, and that is the best. It's just cool.
Reverend Perry?
Yeah, I was remembering something you had said about no one has to go blind, basically, with the science that we have. What are some of the new innovative things that in your field that makes you say that with such positivity?
Yeah, absolutely. So 40 years ago, we figured out how to do laser for diabetic retinopathy. 40 years ago, that's when it was invented. And, we've iterated since then, but we were able to prevent blindness even then, right? And now our technology is much better. We've had in the last, I would say like 10, 15 years, the advance of injections in the eye. And it's exactly like it sounds. I know it's super scary, but it works great, right? And so we inject the eyes and it changes the environment in the eye. It's something called anti-VEGF, vascular endothelial growth factor. And basically that's what happens when we talked about those blood vessel changes and that environment inside the eye, it gives off VEGF. And so basically there is a chemotherapeutic medication that is an anti-VEGF that a researcher tried and said, maybe this will work in the eye because I know this is one of the proteins or compounds that are, causing this environment. And lo and behold, we were able to get those vessels to dry up. It's actually a class of medications that we also use for macular degeneration. So we can treat macular edema in a way that we couldn't before. We could only kind of laser that area of central. Now we can inject. So the treatments work. There is a large treatment burden. I think that makes it difficult for some folks in our communities as well. I always tell people I need to see you every month when we start this kind of treatment, every month, 6 to 9 months. For me to say, yes, this is going great, or no, it's not. I think that's a long haul. It's a lot of visits. It's more than most people's primary care doctor. So now the new advances in this world are what we call drug durability. So can we put something in the eye? Can we change the molecules so that it lasts longer? Can I get something that's like a 3-month something or a 4-month something? So I just have to come a few times a year. There are some advances and some testing for some oral medications that have been shown to be able to stabilize diabetic retinopathy in the eye, which I'm advocating for our communities, because we can probably take a pill. And if I can take a pill and leave my eyes the way they are, that's what's really important as well. So I also think that from the diabetes side, we have beautiful advances in diabetes medications. A lot of those medications are getting a lot of prime time for their weight loss, but glycemic control for the pumps, I think, are wonderful when you can manage one's blood sugar without going too low. I think continuous glucose monitoring has really changed the game to try to tell people where their blood sugar is at a particular moment, to try to give people the data to be able to manage that, because we know that's one of our leading drivers and risk factors. So, the adage of retina specialists was always, if you can get them to me, I can do it, right? If you can get them to me on time, I can save their vision. And it's true, we have a lot of, tools in our arsenal. But I do think that we have to interrogate our systems with regards to the how of getting to people and who, right? And so, my clinic is bursting at the seams. It is. It really is. Like, it's really hard to get to me. I think my next new visit is maybe in, don't quote me, what's this month? Probably in August, something like that, like to be able to come and see me, because there's just so much. And so, I'm advocating for them to give me a high-risk diabetes clinic, because I'm really concerned about our community members, and I want people to have a space to go if I think that you're high risk, so that we can have a protected space for you with someone that has a high level of expertise in that area. But that doesn't really exist. But I think that we have to figure out what are the systems, what are the things that we can do. Some of my friends, I have colleagues in Michigan that have done some work in Flint and done some work in Ypsilanti, trying to figure out telehealth models. So are there other models of care that we have close contact with eye professionals, but also can we extend our reach using telehealth? This is also something that the pandemic kind of solidified as well, as something that we can do to extend while we figure out how to get everyone a comprehensive eye exam. So we're trying to figure out what are those pieces. Also in ophthalmology and in retina in particular, there is autonomous diagnosis. So we have artificial intelligence embedded into cameras that can detect diabetic retinopathy and get reimbursement for that on their own. So we're trying to figure out what are the models to be able to incorporate that in current systems. The problems are now, guess what? What happens when you find something is still what we're battling with. And what happens, like Reverend Clayton was saying, the social determinants of health of when I need somebody to come back because I see something that I'm worried about, particularly in eye disease, because you can have really bad eye disease and be 2020. It could be 2015. And just we look inside and we are really worried about it. But that disconnect is really challenging. Being able to share images of the eye is helpful, but trying to not scare someone so much that they don't come ever again, but also to impart the urgency of that situation is something that's really important. And I think we are trying to find models, Reverend Clayton, about how to manage someone's social determinants for them, right? Yes. And so for our study, we found that there were certain determinants that our participants were interested in having addressed, and certain ones that they said, nope, I'm okay. And a lot of them really liked the program because they wanted to talk about what was available to them, but they didn't need everything fixed, right? They didn't need everything addressed, and nor did they want that. And I think that once again, as we start to listen to how we operationalize these pieces, and Mr. Amos Smith, the work that they're doing, I got to visit over there, 7,000 families a year, mind blowing. And there's a lot of humans in New Haven that are just doing this beautiful work, and then being able to accentuate their expertise and join up together to get us all healthy is where we have to be. So I'm just trying to support and be on the team. Put me in the game, coach, right?
Dr. Onwanyu, we have about 30 seconds, but I would be remiss if I didn't ask if people want to kind of reach out to you or pursue how they can participate in your research endeavors. What's the best way for that? Best way for that to happen? Okay,
so we're on Instagram at Scene Lab Yale, which is exciting. We also have an email address. It is scene, SEEN program, program at yale.edu. And then I'll also email all of that too, so you have it as well. But we would love to connect. And like I said, we'll be at the Q House this summer. So if you see some small doctor hanging out, partying with the DJ, it's me. So come and hang out.
And I believe the ambassadors are having a health fair also earlier in June. So the collaboration is so key.
Yeah, man, it's perfect.
We got to go. Unfortunately, we got to go. We got to do it again. Thank you so much, everyone.
Anytime.
Thank you.
This was a delight. Thank you all so much. I appreciate it. I would do that over and over again. You're the best.
You're back. We got your back.
Thank you.
Thank you so much.
As I got another rhyme, another rhythm for y'all to listen. I'm never quitting on my mission. I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going, better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain. Keep on working, open curtains, haters swerving, cause they ain't ready for your final version. Whoa. I'm never gonna give up. Fall down, I just gotta get up, yeah.
You're listening to the Tom Ficklin Show on WNHH LP 103.5 FM, your home for community radio.